Hello, everyone, and welcome to the World Thrombosis Day 2018 webinar, co-hosted today by the International Society on Thrombosis and Haemostasis, abbreviated ISTH, and by the Division of Blood Disorders at the Centers for Disease Control and Prevention in the United States, also known as the CDC. Today's webinar is titled Hospital-Associated Venous Thromboembolism, What You Need to Know. I'm Jeffrey Raskov, and I'm honored to be the moderator for the webinar today. I serve as Dean of the College of Public Health and Regents Professor of Epidemiology and Medicine at the University of Oklahoma Health Sciences Center in the United States. It's also my privilege to chair the World Thrombosis Day Steering Committee. World Thrombosis Day is a year-long campaign that culminates on October 13, the birthday of Rudolf Virchow, and focuses attention on the often underlooked and misunderstood condition of thrombosis. Specifically, we're focusing on venous thromboembolism, or VTE. This year, we're celebrating the 5th anniversary of World Thrombosis Day and are proud to share that the campaign has more than 1,500 partners this year, representing nearly 100 countries around the world. And we're truly excited that registration for this webinar is at around approximately 450 people. So why don't we get started? Really an honor to introduce today's presenter, Dr. Jeffrey Weitz. Dr. Weitz is Professor of Medicine and Biochemistry and Biomedical Sciences at McMaster University and Executive Director of the Thrombosis and Atherosclerosis Research Institute. He also serves as a member of the World Thrombosis Day Steering Committee. He is board certified in internal medicine, hematology, and medical oncology, and as such focuses his clinical practice on patients with thrombotic disorders. Dr. Weitz's research spans the spectrum from basic studies in the biochemistry of blood coagulation and fibrinolysis to animal models of thrombosis and clinical trials of antithrombotic therapy. The breadth of his work is highlighted by more than 500 publications in journals as diverse as the Journal of Clinical Investigation, Journal of Biological Chemistry, Biochemistry, Circulation, Blood, Annals of Internal Medicine, the New England Journal of Medicine, and Lancet, to name some, as well as over 60 textbook chapters. Dr. Weitz is recipient of numerous awards. He is a Fellow of the American Heart Association, the Royal Society of Canada, and the Canadian Academy of Health Sciences. Dr. Weitz joins us today to discuss the topic of hospital-associated venous thromboembolism, what you need to know. Jeff, thank you so much for being with us today. Really privileged to have you present the webinar.
And it's my pleasure to be here today, Gary, and to talk about something near and dear to my heart. I'd like to first show my disclosures. I'll give the audience a moment to read them. What I want to focus on in the next 20 minutes or so is to provide an awareness of the scope of the problem of venous thromboembolism, or VTE, in the hospitalized patient setting, to understand the determinants of risk of venous thromboembolism, and to talk about a real-world approach to VTE prevention or thromboprophylaxis. Let's provide the facts. As most of the attendees know, a blood clot that forms in the leg is called deep vein thrombosis, or DVT, and some of these clots can break loose, travel up to the lungs to produce a pulmonary embolism, or PE. Together, DVT and PE are known as venous thromboembolism, or VTE. 1 in 4 people worldwide die from thrombosis, from blood clots. The top 3 cardiovascular killers are heart attack, stroke, and VTE, and all of these are blood clot related. Pulmonary embolism is the number one cause of preventable death in hospitals. And 60% of all VTE cases occur during or after hospitalization. Now, because VTE is such a major problem, we have many organizations in Canada that seek to raise awareness about thrombosis. And I've listed just some of them on this slide. We also have campaigns at the hospital to try and promote awareness about VTE. And here you see at rest, or at risk. Be aware, be proactive, prophylax, indicating that hospitalized patients, because of immobility, are at increased risk for deep vein thrombosis and pulmonary embolism. And to prevent that risk, they should receive prophylaxis. We've talked about the burden of disease, thrombosis being responsible for 1 in 4 global deaths. But to put the VTE burden in perspective, we estimate that there are at least 500,000 VTE-related deaths in Europe each year, and 100 to 300,000 VTE-related deaths in the United States each year. Therefore, VTE is a major healthcare concern. To prevent VTE, people need to be aware of the problem. That's both the public, patients, and physicians, so that appropriate prophylaxis can be instituted. When the World Thrombosis Day group and the ISTH did a global survey of awareness about thrombosis, I'm going to show you the Canadian results summary, and you can see that Canada was lowest among countries about awareness of pulmonary embolism and deep vein thrombosis, despite all the attempts we have at increasing awareness. So we clearly have to do better. Why is it important to prevent thrombosis? Hospitalization increases the risk of VTE about tenfold. About 1.7% of medically ill patients develop VTE within 3 months of hospitalization, and up to 60% of patients who present with VTE have a history of recent hospitalization, and 75% of fatal PE occur in medical patients. This is why pulmonary embolism, or PE, is the number one cause of preventable death in hospitalized patients. Now, when thinking about thromboprophylaxis, we need to understand the risk factors, the relative risk of VTE in association with these risk factors, and the absolute risk as well. Gary mentioned Rudolf Virchow. In the 1800s, Virchow proposed the triad of conditions that promote clotting. These include slow blood flow, venous stasis, vascular injury, so injury to the vessel wall, and increased clotability of the blood. Virchow was born on October 13th, and that's why this date was chosen for World Thrombosis Day. Now, we have a number of VTE risk factors. Of course, the top two, recent surgery with hospitalization and trauma, increase the risk from 13 to 22-fold. But look at the ones that I've outlined in red. Even hospitalization without surgery or malignancy with chemotherapy reduced the risk at least 7-fold, and malignancy without chemotherapy about fourfold. So there are many factors which increase the risk of venous thromboembolism in hospitalized patients. Now, we can assess the risk of thrombosis using various risk assessment models, or RAMs. This chart provides an example of one such RAM that's used to assess the risk of venous thromboembolism in surgical patients. This is known as the Caprini score because this score was developed by Joe Caprini, who is a vascular surgeon. Anticoagulant prophylaxis prevents symptomatic and fatal pulmonary embolism in medical patients. In this 2007 meta-analysis of trials, you see the summary statistic at the bottom that anticoagulant prophylaxis reduces the risk of symptomatic PE by about 60%. A more recent update in 2011, which included many more such trials, also showed a significant 30% reduction in symptomatic pulmonary embolism in medical and stroke patients given anticoagulant prophylaxis. If we take the data from the 2007 meta-analysis, we see that the number needed to treat with anticoagulant prophylaxis to prevent one fatal pulmonary embolism is 400, and the number needed to treat to prevent one symptomatic deep vein thrombosis is 196. What do these numbers mean? Well, to give you some perspective, if we think about mammography to prevent breast cancer deaths, the number of women aged 40 to 49 years needed to screen to prevent a death is over 2,000. When you get to 50 to 69 years, it's 721, and at 70 to 74 years, it's 451, a similar number needed to screen in this case as the number needed to treat to prevent a fatal pulmonary embolism. So we have hospitalized medical patients who are at risk. How do we assess this risk, and how do we provide prophylaxis? There are any number of VTE risk factors in medical patients that put patients at high risk, probable risk, or possible risk. One approach that has been promoted is to just give everybody thromboprophylaxis, but this strategy has problems because the rates of symptomatic VTE vary widely across unselected medically ill populations, with some patients being at high risk and other patients being at low risk. And thromboprophylaxis with low-dose anticoagulation does not confer the same risk reduction in all patient groups. Therefore, if we just try and give everyone prophylaxis, we may not reduce VTE in medically ill patients, and we could increase the risk of bleeding. Instead, the American College of Chest Physician guidelines in the 9th edition suggested that for non-surgical, non-orthopedic patients, a shift towards individualized approach of risk assessment for appropriate thromboprophylactic strategy. And embracing this concept, the ISTH World Thrombosis Day group put out a call to action for global VTE risk assessment for patients entering the hospital, and effective January 1, 2017, the Centers for Medicare and Medicaid Services, CMS, mandated VTE risk assessment for every patient admitted to the hospital. And such assessment is mandated in Canada as well, and hospital accreditation is based on this is one of many criterion to ensure patient safety. Now, how do you implement VTE thromboprophylaxis in the hospital setting? And these are 7 steps to improve the success of VTE prophylaxis. You need commitment from the hospital. You need a committee of individuals who are dedicated to ensure that DVT prophylaxis occurs, and you need a champion for this process. The hospital must have a written policy on thromboprophylaxis that should be simple and standardized. Who gets prophylaxis and with what? Order sets, computer order entries, and decision support can simplify the implementation of prophylaxis, and we need to make a prophylaxis decision mandatory on admission for every patient. The team should include everyone: physicians, nurses, pharmacists, and patients. Patients with knowledge can advocate for appropriate thromboprophylaxis, and then implementation needs to be audited. The audit information needs to be sent back to the team, and improvements can then be done as needed. Now, an ideal risk assessment model for medical patients should enable the accurate identification of patients who meet a threshold risk for DVT in the absence of prophylaxis. It should exclude patients who are at high risk for bleeding. It should be evidence-based and validated, and it should be simple to use. We have a number of such models. This is the Padua VTE risk assessment models, and you see the features that are listed here as risk factors, and a score is given for these various factors, and patients are at high risk if the score is 4 or more. Another well-validated risk assessment model is the improved score. Here again, you see the risk factors and the points to determine a risk score. And the improved risk assessment model has been prospectively validated. And you see that if the score is 3 or higher, the 3-month rate of symptomatic VTE is about 3%, and the 3-month rate of symptomatic PE is about 1.4%. The score can be improved by adding a biomarker, that is the level of D-dimer. So D-dimer is a breakdown product of blood clots that circulates in the blood. And if the D-dimer is increased over 2 times the upper limit of normal, this is a risk factor for venous thrombosis. Now, we know that patients are at risk for thrombosis when they are hospitalized, but we also know that this risk can extend for up to a month after they go home in certain patients. So what about extending the duration of prophylaxis beyond the hospital stay? And this gets important as the pressure is on to get patients out of hospital quickly. The 2012 American College of Chest Physicians and 2013 International Union of Angiology recommendations about extended prophylaxis in medical patients, the ACCP suggested against routine extension, and the International Angiology Group said that extended duration of thromboprophylaxis may be considered in high-risk patients, and they identified female patients, those over the age of 75, or those with severe immobility might be candidates for extended thromboprophylaxis. We have had a number of trials comparing extended thromboprophylaxis for a month with a shorter duration of thromboprophylaxis, and these trials have yielded mixed results. All of the trials have shown that extended prophylaxis reduces the risk of major VTE, but with some of the agents, extended thromboprophylaxis has increased the risk of major bleeding by a significant extent, so that the benefit is offset by the increased risk of bleeding. Therefore, I think at this point, we still are not yet there in identifying the highest risk patients who should get thromboprophylaxis beyond the hospital stay. I'm sure that some patients should, but all patients at risk should get thromboprophylaxis while in hospital. So in conclusion, appropriate thromboprophylaxis is essential for reducing the burden of hospital-associated VTE, and remember that fatal PE is the number one preventable cause of death in hospitalized patients. VTE risk should be assessed in all hospitalized patients, and to ensure that this occurs, we urge you to join World Thrombosis Day to improve awareness and reduce the burden of thrombosis. And you can join us at the worldthrombosisday.org website. Thank you very much for your attention. Gary, I'm going to hand it over to you.
Thank you. Thank you, Jeff, for that very clear presentation, very clear and complete, concise review of the area. We do have some results for the poll, and those are interesting. I'll just summarize a couple things. We have individuals on the call from North America, South America, Western Europe, Africa, Asia, and so we really appreciate the interest globally, and particularly those who are staying up late or getting up very early in time zones across the world for this presentation. Also, we have a wide range of health professionals represented on this, including physicians, nurses, pharmacists, and many others who are involved in the care. And that's really great news because I think, as Dr. Weitz pointed out, having a good program for prevention of VTE requires a good multidisciplinary team. So I think that we can now move on to some questions that there may be for Dr. Weitz. I would say, please, again, you can enter your question and send that to us in the question box on the left-hand side of your screen. We're monitoring those. And I will start, Jeff, with a question. So prophylaxis in hospital, which anticoagulant prophylaxis in hospital, which drugs should be used?
Great question, Gary. Most hospitals these days are moving to low molecular weight heparin. We used to use low-dose unfractionated heparin. That has to be given subcutaneously twice a day, whereas low molecular weight heparin can be given once a day subcutaneously. So for in-hospital thromboprophylaxis, mostly with a heparin. Some high-risk patients, such as the orthopedic surgery patients, might get low molecular weight heparin or might get one of the direct oral anticoagulants, such as a low dose of rivaroxaban or apixaban for thromboprophylaxis after their surgery.
Great, thank you very much. And so, in that same vein, what's the role of intermittent compression devices in this effort? And then what do we do to ensure compliance with the intermittent compression?
Yeah, and that's the problem with intermittent compression devices. I often prescribe them, and when I go into the patient room, I see them sitting at the bedside and not turned on. So they only work if they're turned on. I think the major place for compression devices is for patients who are at high risk of bleeding and can't tolerate chemical prophylaxis with an anticoagulant. That's where compression devices are used in my center.
Great, thank you. We have a question that's come in, which is, what should a patient who has upcoming surgery discuss with their healthcare team? Maybe we'll address the surgical patients for a few minutes and then switch over to some questions about medical patients.
Yeah, and in fact, Gary, the surgical patients are actually easier to address because, again, depending on the type of surgery, is it going to be open surgery? Is it going to be laparoscopic? Are the patients just going to be in for the day and go home the same day? Are they going to stay in hospital, etc.? We can determine the need and the type of thromboprophylaxis. For certain types of surgery, like orthopedic surgery, for knee replacement surgery, hip replacement surgery, surgery for hip fracture, we know those patients are at high risk of venous thromboembolism without thromboprophylaxis, and all of those patients should get thromboprophylaxis. And for those patients, we tend to extend it for at least 2 weeks in the knee replacement patients and for about a month in the patients undergoing surgery for hip fracture or in those undergoing hip replacement surgery. Patients undergoing pelvic or abdominal surgery for cancer, for example, those patients are routinely given a month of thromboprophylaxis, usually with low molecular weight heparin after the surgery. So depending on the type of surgery, the type of duration of prophylaxis might differ. So the patient, knowing that they will be that may be at risk for thrombosis, should discuss this with their surgeon.
Yeah, so I think it's fair to say a reasonable thing would be for any patient having surgery just to ask their surgeon, about this, bring it to their attention. Following on that, I think you sort of touched on the prophylaxis out of hospital and the duration. What we see in recent years, of course, is the duration of hospitalization for many of these surgeries is coming down very, very significantly. But does that mean we just give prophylaxis in hospital, or what's a general minimum duration we should use for the groups that don't fall into the extended prophylaxis that you discussed?
That's a great question, and we don't really know. But if they're going home, and even like knee surgery patients, some of them are going home the next day, Gary, and obviously that's not, if you just give them 1 day of prophylaxis, it's not enough. So out-of-hospital prophylaxis for these patients is important, and, it would be reasonable for, after any type of major surgery, to give prophylaxis for at least 2 weeks until the patient is mobile again. Maybe it's shorter if the patient's surgery was less invasive. Great.
Moving over to the medical patients, this is where we still have a lot of work to do because I think, as you mentioned, or maybe we just recap, is it not the medical patients where most of the fatal pulmonary embolism events occur?
Yes, as I mentioned, 75% of the fatal PEs are in the medical patients, not the surgical patients. So that rather surprising number says we have to do better for our medical patients. And the population is aging. The older patients have more complex medical problems. They have more comorbidities, and they tend to be sicker. And yet hospital stays are shortening, and just giving prophylaxis while they're in hospital for 2 or 3 days may not be enough.
Right. So you had a very nice slide about the results of the trials now of extended thromboprophylaxis in medical patients, which showed some important messages. I think the more recent trials, the APEX trial and the Mariner trial, suggest we've found regimens that are much safer now. We've gotten over that very high risk of bleeding issue. But what do you conclude about the risk-benefit based on these data? And then maybe some guidance. Who would you choose for extended thromboprophylaxis now in medical patients, in line with that angiology recommendations?
Yeah, I think, Gary, that the APEX trial and the Mariner trial tell us that medical patients do remain at risk, and that extended thromboprophylaxis reduces the VTE burden. The problem still is how to identify the highest risk patients. I think the highest risk patients are those who are over 75 years of age or older, who have cancer, and those who have an elevated D-dimer of more than 2 times the upper limit of normal. I think with those criteria, we could identify some of the highest risk patients.
Yeah, so clearly it becomes important role for the physician in risk-benefit choice here, but everyone should have a risk assessment, and then we look at what to do within the highest risk group.
And I see, Gary, that 2 questions from the audience. Someone said, well, do we need new biomarkers and not only D-dimer? Well, of course, we're always looking for new biomarkers, but at the present time, D-dimer seems to be the best. And someone else asked, why are women at high risk of venous thromboembolism? And this came from the international angiology recommendations. I'm not sure that women are at any higher risk of hospital-associated venous thromboembolism than men. I'm not quite sure why they had that in their recommendation.
Great, thank you. And following on, the D-dimer, of course, is very important, played a role in both the APEX study and the Mariner. Is the evidence for the D-dimer as a risk marker now robust enough to use this in clinical practice in medical patients?
I'm not sure we're there yet. I think it will prove to be a very good biomarker to identify the highest risk patients, but there would have to be a lot of education around the D-dimer, because the use of the D-dimer right now is mainly to use it to exclude a normal D-dimer, to exclude the diagnosis of VTE. Now we're using an elevated D-dimer to identify patients at risk. There'd have to be a lot of education around this changing use. So I'm not sure we're yet at the point where it should be implemented in a blanket fashion. I think we need a little bit more data to help to incorporate it into a set of criteria that identify the highest risk patients who might benefit from extended thromboprophylaxis.
Great. And so while we're on this topic of lab tests, biomarkers that reflect, when we give thromboprophylaxis in hospital or out, does that need to be monitored with the coagulation test, or have the regimen adjusted, or is it a different approach?
No, when we're giving the anticoagulants for thromboprophylaxis, whether it's low molecular weight heparin or a low dose of rivaroxaban, for example, these anticoagulants do not require monitoring. If we were using warfarin for extended thromboprophylaxis, then that does need to be monitored to ensure that the anticoagulant effect is in the therapeutic range.
Good. This is always an interesting question in an evolving area. Is there any role for aspirin in thromboprophylaxis?
Yeah, that's a great question. We know that aspirin is less effective than anticoagulants for prevention of venous thromboembolism. But it doesn't mean that aspirin is ineffective. And a recent Canadian study in patients undergoing hip or knee surgery showed that after 5 days of rivaroxaban, patients were randomized to extended prophylaxis with either aspirin or with more rivaroxaban, and there was no difference in the two treatment regimens in terms of symptomatic VTE or bleeding. So it's possible that aspirin may have a role, but even in that study, remember, all patients got 5 days of rivaroxaban before getting randomized to extended treatment with aspirin versus rivaroxaban. We don't know how rivaroxaban would compare with aspirin right from the get-go. So in general, I would say that give an anticoagulant, and then if the patient's not got a problem with aspirin, if they need extended thromboprophylaxis, maybe you could use aspirin for that.
Yes, in the orthopedic setting.
In the orthopedic setting. I don't know about the general medical setting, and a lot of patients are on aspirin anyway for cardiovascular reasons.
Right. So that leads to another question, as we mentioned. So what is the appropriate dose of rivaroxaban for prophylaxis?
Well, in the orthopedic patients, it's 10 milligrams once daily. That's the dose that was used in the Mariner study, as you know, for extended thromboprophylaxis. Rivaroxaban is not licensed for thromboprophylaxis in medical patients, only for the patients undergoing elective hip or knee replacement surgery, and extended in some cases to those undergoing surgery for hip fracture.
Good, thank you. There's, I think, an astute question came in here that, there's still clearly significant heparin use in hospital and for a number of areas, and in some centers that may not have resources for low molecular weight heparin, probably unfractionated heparin still gets some use around the world. What about heparin-associated thrombocytopenia? What should we think about that? Is that still a problem?
That's definitely a problem. And remember that heparin-induced thrombocytopenia presents after patients have received heparin for somewhere at least 5 to 10 days. So the longer you give unfractionated heparin, the greater the risk. Now, surgical patients are at higher risk for heparin-induced thrombocytopenia than medical patients, but it does occur, and that's one of the reasons why we've made the shift from unfractionated heparin to low molecular weight heparin, because of the lower risk of heparin-induced thrombocytopenia with low molecular weight heparin, and that then means that it's no longer necessary to follow the platelet counts.
Great. Now, you mentioned the risk is lower with low molecular weight heparin, but it still can occur. Is that correct?
That's right. It's lower, but it still occurs, but much less frequently. Fondaparinux, the synthetic pentasaccharide, is not associated with with HIT, or exceedingly rarely associated with HIT, but it's more expensive than low molecular weight heparin. It would be another alternative.
Okay.
For surgical patients or for medical patients, but it's not often used because of the cost.
Great. Well, we've covered a lot of really good questions from our audience about specifics of prophylaxis. There's some other good ones that came in just now, turning back to the general area of VTE risk assessment. And I think one question, this came from a few, it's something that is commonly asked, I think, and what is the role of genetic testing? Should we check these patients for gene mutations that predispose to thrombosis before they have their surgery or when they're admitted to hospital?
No, I really would not recommend doing that, and let me tell you why. I showed you that, for example, that if a patient is hospitalized and undergoes surgery, the risk of VTE increases about 20-fold. That 20-fold increase in risk is far greater than the increased risk associated with any of the thrombophilias. So regardless of whether the patient has thrombophilia or not, all patients at risk should get thromboprophylaxis. So knowing that they have or don't have thrombophilia really won't change things. The only thing is that if the patient has a family history and they happen to have thrombophilia, then for sure you're going to give thromboprophylaxis, and you might consider extending prophylaxis in those patients. But again, depending on the surgery, for example, you probably would anyway.
Yes, thanks. So on the topic of risk assessment, maybe we can review. You had some very nice slides and summary in your presentation about the different models. Which risk assessment model would we recommend to be used?
Well, I like the IMPROVE score, Gary, because it's been very well validated. So, and it's simple. So that's one that's often used, and you know, it's much simpler than, say, that Caprini score that we use for surgical patients, which takes up a page in small writing and difficult to see. So simple is better. And we want a model that's been validated. So that might be one. The CHEST guidelines recommend the Padua risk assessment model. I don't think it really matters as long as you use something.
Yeah, good. So is it fair to say the risk assessment approach is really, in terms of these risk assessment models, is really much more important in the medical population because, as you outlined, the different surgeries almost drive the decision just by knowledge of the surgery. Is that a reasonable generalization?
Exactly. I think that drives the type and duration of thromboprophylaxis, depending on the type of surgery, more than anything, and especially, you know, is it surgery for cancer or not, that sort of thing. Whereas for the medical patients, the challenge there is that it's much harder to identify the patients at risk. They come in, you don't know how active they're going to be when they come into hospital, and so you have to keep reassessing the patients. Maybe they come in and they're up and walking right away, but other times they come in and really you find them in bed every time you see them. So it's much harder to assess the risk of VTE in the medical population. They're much more diverse.
Yes. Great. There have been now a few more questions coming in about more details about thromboprophylaxis. So, and these are very good questions. Our audience has been terrific. Is there a role for warfarin for extended prophylaxis? And if so, what's the appropriate INR target?
Yeah, I mean, warfarin is an option for extended prophylaxis, certainly in the patients undergoing joint replacement surgery. It's a little cumbersome because you have to dose adjust to achieve an INR between 2 and 3. Okay.
Can we use rivaroxaban for prophylaxis in the cancer patients?
Great question. We don't really know the answer to that yet, but studies evaluating low-dose rivaroxaban and low-dose apixaban for primary prophylaxis in high-risk cancer patients are completed, and we expect to see the results of those studies in December at the American Society of Hematology meeting. This is the AVERT study with apixaban and the Cassini study with rivaroxaban.
And those are ambulatory cancer patients undergoing chemotherapy.
Cancer patients, not hospitalized cancer. Ambulatory cancer patients getting treatment for the high-risk cancer patients getting treatments.
Great. Yeah. Rivaroxaban was evaluated in the Magellan study and some of the others, and betrixaban in the cancer patients. So hospitalized cancer patients who are then going home, what would you say for extended prophylaxis?
I would think if I had a hospitalized cancer patient who I think is at high risk and going home, I think extended prophylaxis with rivaroxaban or betrixaban, if that's available on your formulary, would be very reasonable.
Good. Terrific. Here's an interesting question, a tough one, I think. What about patients with sickle cell disease? They're not well represented in these studies. What do you recommend for those patients?
Yeah, that's a great question. Patients with sickle cell disease, I mean, there are other methods to reduce sickling, and there are studies going on with new treatments, but I think they are just as at risk for thrombosis as anyone else, and we typically use heparin or low molecular weight heparin for prophylaxis. It would be reasonable also to use the rivaroxaban or apixaban for the surgical patients as per indication.
Terrific. I think that we've covered cancer. A couple more questions. Do we have any evidence that using a risk assessment model, VTE risk assessment model, will reduce healthcare costs?
I don't think we have solid evidence that that's the case, but by reducing the risk of the burden of VTE, by reducing VTE, we reduce hospitalization because, as I said, the patients remain at risk for up to a month after they go home. So if we can reduce rehospitalization and reduce the need for treatment of a documented VTE, obviously it should reduce healthcare costs.
Yeah, thank you. And this gives a chance just to give a mention to our CDC colleagues who are on the phone who did great work on this regarding the contribution of venous thromboembolism to direct healthcare costs in the United States. So the incidental venous thromboembolism, so the new events of venous thromboembolism, have about an estimated incremental cost in the U.S. over and above all the other things that these patients incur because they're sick already or have issues. But the cost attributable to venous thromboembolism in the United States was estimated by our CDC colleagues to be at about $10 billion a year. And clearly, if we can reduce that, we will have some impact. Of course, there's a cost for the medications and so on, but in many other settings, Jeff, I'm right that studies which have evaluated cost effectiveness of prophylaxis in surgical patients, for example, have shown it to be quite cost effective. Is that right?
Sure. That's correct, and I'm sure the same is true in medical patients.
Now, for extended prophylaxis, these trials, can we generalize them to any of the direct oral anticoagulants? For example, there was a question here about edoxaban. I don't think that was studied in anything beyond the hip replacement, but are you comfortable generalizing, or should we try to use the
I think we need to use the drugs and the doses that were tested because we don't know whether the same findings would occur with the others, especially remember that for rivaroxaban, it's the prophylactic dose. We don't know exactly what the prophylactic dose of edoxaban might be.
Yes.
It'd probably be 30. It wouldn't be 60, but it hasn't been tested.
Great. We've had a couple questions come in now on what I think is a very important and evolving area. That is patients with antiphospholipid antibody syndrome and triple positive, or with the systemic lupus. Do the direct oral anticoagulants or NOACs, do they have a role? What should we do with these patients?
I think this is high-risk antiphospholipid syndrome patients, so those patients who are so-called triple positive, just this month, there was a paper published in Blood on the TRAPS study, which the trial on rivaroxaban in antiphospholipid syndrome, TRAPS, which compared rivaroxaban with warfarin in triple-positive patients with antiphospholipid syndrome, and there were more thrombotic events and bleeding events with rivaroxaban than with warfarin. So I think for the moment we should use warfarin and not a direct oral anticoagulant in our highest risk antiphospholipid syndrome patients until we have more data.
And how would you deal with the prophylaxis with those patients then if they're hospitalized?
Well, I think that those patients are definitely at risk for thrombosis, and I would simply, if they were on warfarin, then what I would do is I would have to stop the warfarin before their planned, if we're talking about surgical intervention, before their planned surgery. Those would be patients where you could consider preoperative bridging, and then after surgery, I would get them started back on their warfarin as soon as possible, and I would give them prophylaxis with low molecular weight heparin until their INR is back in the therapeutic range.
Good.
If they were medical patients, then if you can at all, I would keep them on their warfarin through the course of their stay. If they can't be kept on warfarin, I would stop the warfarin and I would give them low molecular weight heparin.
So this applies to individuals with the antiphospholipid antibody syndrome, even if they've not experienced a clinical evidence of thrombosis, or is it only for the one?
They can't have. The definition of antiphospholipid syndrome is that they have had a thrombotic episode,
yes,
or at least had the complications of pregnancy. So most of these patients are patients who had thrombosis. So they would be like any high-risk patient who comes in for medical illness or for surgery.
Good. And I think we're coming down to the time, so we'll end off with one last question, but this is always an interesting question, sometimes debated. Is it necessary to monitor anti-factor Xa activity if you're using the direct oral anticoagulants, rivaroxaban or others? Are there special situations where you would want to monitor?
Yeah, I don't think that you ever need to monitor, because monitor means to me you're going to measure the level and do something with that level about the drug dosage if you find a high level or a low level. I think occasionally it's maybe useful to measure anti-factor Xa activity. If someone is on one of these drugs and they have major bleeding and you want to determine whether the anticoagulant is contributing to the bleeding, measuring the anti-10A activity in someone taking rivaroxaban or apixaban might be useful. But we're talking about thromboprophylaxis with the thromboprophylactic doses of these agents and with low molecular weight heparin. The anti-10A assay is rarely going to be useful.
Good. Thank you. Well, want to first of all thank our participants for just a lot of wonderful and really thoughtful questions. We've come to the end of our time for the question and answer. I want to give Jeff you a chance for any concluding remarks.
Well, I just want to thank everyone for attending this webinar. I also want to give a huge shout out to ISTH for supporting this initiative and for bringing attention to World Thrombosis Day and to thrombosis in general, and to the CDC for their support of this activity.
Thank you very much, and we would like to thank you, Dr. Weitz, for this really important presentation, and we hope that I'm sure that our audience has found this useful. To our audience following this presentation, you'll receive a recording of the webinar. We encourage you to visit the website at worldthrombosisday.org to learn more about the World Thrombosis Day awareness campaign. And this is, again, October 13, and we're celebrating the 5th anniversary with more than almost now 1,500 partners. And also see the link to the CDC, which is shown so that you can go there for the webinar archive page. Thank you very much for participating. We appreciate very much your support of World Thrombosis Day and all you're doing to reduce the burden of thrombosis. Thank you.